Thank you so much for that wonderful introduction. I don't know how I could possibly match that introduction, but I'm going to try. It's wonderful that everybody joined tonight. You could be anywhere on the planet, but you're here on this webinar with me, and I really appreciate that. How many of you just sitting here listening have ever wanted to write a book? If you think about it, some of you are thinking, wait, you mean a fictional book, non-fictional book? What kind of book? Well, the nerd in me has always wanted to write a textbook. And I don't know if I'll ever get a chance, but it was a thought in my mind when I thought about the idea of postoperative care. And the reason why I thought about it is because it can be particularly complex. It involves multiple specialties and multiple minds to maximize the outcomes. And so whether you're talking about short-term, mid-term, long-term care, or just how a patient's needs change throughout their time in the hospital, I do think the topic or the subject of postoperative care is a pretty fascinating one. And so ideally, there would be this postoperative care Bible, right? Where you can finish a particular procedure and then the story picks up in the book right when you're walking out of the OR about what that particular patient needs. So that's where the inspiration came for this discussion. But what I realized very quickly is that this topic is extremely expansive and we only have a few minutes. So we won't obviously get to all the nitty gritty of postoperative care, but it'll just be over a high level discussion. Now, as you can see here, we're talking about conventional possibilities, and we're also talking about untapped remedies. So things that I think, will be introduced in the future regarding postoperative care. So a lot of the things you're going to hear today are, hey, yeah, reminders. There are other things, though, that might be good to incorporate. So here's an example of just us technically where the actual journey begins.
Okay, so procedure performed. This was Fig. She was a 6-month-old domestic short hair calico. She was presented for an abdominal exploratory for a foreign body. Sponge sharpen instrument count. Good. Sponges are 5. Instruments are there, and then sharps are appropriate. Specimens identified and labeled. No. Does not apply. Equipment problems to be addressed?
No.
Post-op rads needed?
No.
Discussion of wound classification?
Clean?
Okay. No purse string to be removed. We are not going to express this cat's bladder. Can she have NSAIDs?
No.
No NSAIDs. Plan for dysphoric recovery? Yes, we have that. No need for oxygen cage or support?
Correct.
Is she going to be continued on IV fluids?
Yes.
And what is your rate?
50 mils per kg per day.
Okay. Analgesia?
Methadone?
0.1 mg per kg?
Correct.
Q6?
Correct.
Gabapentin?
Yes.
Post-op treatment sheet has been finalized. Any special instructions for ICU?
No.
No CETA has been administered?
Correct.
How is your team performance?
Excellent.
Any key events that need to be addressed?
Single enterotomy, single gastrotomy complete, and unremarkable remainder of procedure.
Issues to be addressed for a future procedure?
No.
Great.
And we are technically off to the races. Do want to shout out Zomedica for powering this presentation and giving us some interesting pearls, tips, and tricks to discuss. And we will really dig into that towards the end of the presentation. But yeah, we're going to talk about just some of the old standbys, the foundation, including the physical exam, blood work, temperature, pulse. And of course, we'll talk at the end about continuing monitoring. When we're talking about postoperative care, it's important to remember that right there, we're just talking about the immediate postoperative care. What does that patient need immediately after coming out of the OR? And then as they stay in the hospital, their needs will change to short-term. And eventually, many patients may need physical therapy or long-term medications, and that would be long-term care. So again, I think that the postoperative care journey is, I think if there's one theme and motif that I think runs throughout this discussion that we're having today, is that there's changing needs of the patient throughout their journey. And so I do want to just say the first pearl we'll talk about is the postoperative checklist. As many of you know, checklists or making lists in general decrease hospital mistakes, they decrease in-hospital errors, and potentially save lives. So I do like to incorporate a pre-induction checklist, an intraoperative checklist, and then immediate post-operative checklist. And sometimes you may hear critiques against these and that they do add to operative times, but I do feel like when you have a team that's super efficient, you can get through these checklists pretty rapidly, which is wonderful. We have an immediate post-operative checklist. And then once that patient, for those hospitals that are large enough to have a different division, I think a recovery post-operative checklist is ideal as well. There are duplicates there. For example, during that video we were just talking about in immediate post-operative care, they asked me what the wound classification was. And eventually, immediately after the end of the video, I changed that to clean contaminated. But if you are entering a hollow viscous, like a single enterotomy, gastrotomy, that is technically a clean contaminated wound. So it does allow, I think, not only for checklists to minimize mistakes, but it also allows for checks and balances, accountability, so that everybody on the team can be double checked. And I think that that's really important. And then, of course, this is a nice checklist for at-home client communication. So this would be more along the lines of a long-term post-operative care. But there are patients who need shifting or have different changes to their long-term care. There are countless calls that we get for dogs who should be convalescing post-orthopedic surgery. We'll utilize, pharmacologic agents like a trazodone or an acepromazine or even tramadol, right, to decrease those anxiety levels. And there are patients who, throughout their 5-week recovery, they'll need different dosages or different medications throughout that. And so I do think that it's important for those changing needs of those particular patients. The surgical infection rate or surgical site infection rate without the use of a checklist, and 101 consecutive gastrointestinal foreign body procedures were performed using a checklist, and just comparing between the two. And what they found was that surgical site infection rate had a significant decrease from near 20% all the way down to 12% with the use of a surgical checklist. So if we're trying to minimize mistakes in the hospital and minimize infections at home, it's super important to incorporate the use of a checklist, right? And just important enough to remember that the development of an SSI or surgical site infection showed a decreased rate when antibiotics were not prescribed, which is very interesting. It's sort of confounding variable that when you didn't prescribe antibiotics, the infection rate actually dropped. And about 36% developed an infection. And for dogs that had self-trauma, almost all developed an infection. I certainly have had calls where the e-collar or the recovery collar comes off, and the owner says to me, the cone's been off for a few hours. Should I bring my dog in to have it looked at? I said, has she been licking at the incision? They say, no, she has not been licking at it, but she's just been chewing at it for a little bit. Now, when you hear that, that's really unfortunate, because that dog definitely needs to come in. And more importantly is, too, that the postoperative period can be challenging. Between 47 and 60% of all anesthetic-related deaths can occur within the first 3 hours postoperatively. And I distinctly remember this with doing a relief shift at a hospital with a bunch of other doctors. A Maltese, I believe it was a 9-year-old Maltese, who had left a postoperative procedure. I think it was an orthopedic procedure, but had a chronic history of collapsing trachea. And during that hospital visit, a traveling ultrasonographer came in and shut off the lights to complete the 5 or 6 studies that she had to complete. But when they flipped back on the lights, that Maltese unfortunately had passed away immediately in that postoperative recovery period, within that 3 hours, despite having an elective orthopedic surgery, just because it likely had an underlying respiratory event, and it was in that most perilous time, which is in that first 3 hours. So any patient with underlying concerns, any patient period, right, should be monitored closely in the postoperative period, but particularly those who are aged or have underlying comorbidities. We do have a nice scale for entering surgery, right? That is, the anesthesiologist came up with the classification, or the ASA classification, for patients entering the procedure. But as you can see, all the way from 1 to 6, 1 healthy patient, and 6 where we're concerned they're not going to, or I'd just say 5 we're concerned they're not going to make it through the procedure. But We don't have a similar scale for post-operative, meaning you could have a healthy patient who enters the OR and then complications happen during the procedure, particularly, let's say, hemorrhage as an example, and now they're exiting the OR having a much different classification system. Am I about to debut a new post-operative classification scale? Unfortunately, no, I don't have that scale, but I would say it would take several minds, primary care, internists, criticalists, surgeons, all to establish basically a physical condition scale. So, in the absence of an actual scale, I think it's really important to emphasize that the way a patient enters the OR doesn't necessarily mean they'll have the same level of health or classification when they exit the OR. For example, Cheeto unfortunately had a disagreement with a German Shepherd, sustained multiple puncture wounds, traumatic abdominal hernia there, near evisceration there. He's had significant blood loss. He's painful, shocky, and his family's in the lobby trying to decide what's next. You can see also a really large wound on his dorsum as well. So definitely things that we need to think about Cheeto, while he's been in the hospital, his needs will change. So I think first and most important is to get an accurate history, because that history beforehand will also give you an indication as to what their needs are post-operatively. What's their personality? What are their previous medical conditions? What was the nature of the surgery? Did you have to do a gastrectomy after the GDV? What things changed while you were in the OR. For example, you have Sonny here who had a very straightforward splenectomy. He's older, and so perhaps he's having a slightly exaggerated effect to his opioids post-operatively. And so I called the family and I said, he successfully did well after the procedure. However, he does seem to be a little depressed. They said, okay, we'll come down and we'll take a look. They came down, he popped up, he walked outside, tail wagging, went down for a very short walk and then came back inside and then came back on his bed and took a nap. And they said, we couldn't be happier. And I said, you couldn't be happier. He looks depressed. They said, nope, this is exactly what he does at home. He sleeps most of the day, but when it's time to go for a walk, he pops up, he's ready to go, and then he goes back for a nap. And I think understanding their personality is critical, because you might misinterpret a dog who's not doing well, and they're saying that he's exactly normal. Now, clearly, it could be why he was so tired at home is he had a giant splenic mass that nobody had addressed. However, I do think it's important to know their personality beforehand. For example, another example of this would be looking at brachiocephalic airway obstruction syndrome and asking about their personality, history, what kinds of things are they doing at home. And what they found is that regurgitation happens about 34% of the time, and it was 7.6 times higher in French bulldogs. And most important, post-op regurgitation, because this discussion we're having, this conversation today, is about post-operative care, right? Post-operative regurgitation was about 2.5-fold greater in dogs with a previous history of regurgitation. So for every patient that we see who is brachiocephalic, and they could be even coming in for a spay, I think it's so critical that we include that question. Has your dog been regurgitating at home? That way, post-operatively, if you encounter regurgitation, then you can say, okay, this is something that's normal. More importantly, though, is trying to prevent that through prokinetic agents or antiemetic agents so that we minimize any potential for regurgitation. I do think a physical exam is critical too. If you see a patient a week ago, you consult with that patient a week ago and he presents for surgery a week later, it's very, it can be easy per se, or at least it can be convenient, unfortunately, to say, I just saw that patient a week ago, let's move forward. And things could have dramatically changed in that patient. So a lot of times, if you can, just at least get your hands on them, at least get a glimpse at them, at least do a very quick but thorough physical exam, just to make sure that nothing has changed so that it can pop up any post-operative complications. Let's say you have a post-operative patient who has delayed recovery. What are the 4 things we really should be thinking about? Is that patient hypoglycemic, right? Is it of low body weight, low body size? Is that patient hypothermic? Have we have an exaggerated response or a high dose of opioids? or is there a breed-specific issue with their delayed recovery? So those are the top four. Of course, there's a variety of things that can cause patients to have a delayed recovery, but I do think it's really, really important that we think about these four. Number five might be a vascular accident or a pulmonary thromboembolic event. I certainly have had one case over the past 25 years that I've been doing this where during the procedure, a very routine laparoscopic spay, during that procedure, a Doberman, essentially what we believe is had a vascular accident to the brain and never fully recovered. And that's tragic, but those kinds of things can happen. At least we know they're well described on the human side. So hypoglycemia, clinically silent under anesthesia, that's what makes it so dangerous. You can have a decrease in the MAC concentration. That means they can get deep really quickly or light very quickly, and it can cause a high sympathetic tone. So you can see ventricular arrhythmias with hypoglycemia. And so the ones that are most at weight, of course, are the dogs of low body condition and who are fasting diabetics, and also are Addisonians, and of course are neonates. So those are the ones where we're thinking about how is this patient going to have a post-operative recovery? What should I anticipate? Oh, he's young. Oh, this is a diabetic. Oh, this dog's Addisonian. These are the things that can change our post-operative recovery. And so if we have a patient who's received either an inappropriately high dose of opioids or is having an exaggerated response to opioids, we can have patients that are just hypoventilating, right? And we can also have dogs who have a change in their thermoregulatory zone, so they start to pant, right? We know dose-dependent ketamine administration can also cause apnea. So what I would consider is just having these in the hospital, right? Is having your alpha-2 antagonist, your flumazenil, and either use butorphanol as a reversal agent or naloxone. If you're concerned and say, well, I just gave an opioid for pain, pain control, I don't want to reverse that. Now my patient's going to be painful. Just take your dose of naloxone, dilute it to 10 or 1 mil for smaller patients, and then just give 10% at a time to assess the effect. Sometimes you can get away with just reversing about 20 or 30% of the dose and still have that patient either walk out of the hospital or recover faster, or just wake up faster and have a smoother post-operative recovery without having to reverse all of your pain meds. And of course, we have breed-specific changes when we're talking about post-operative recovery, right? This patient, Schnauzer, develops pancreatitis post-operatively. Not a surprise. We know that Schnauzers are predisposed or at least overrepresented for pancreatitis. Herding breeds, we know that we have to be careful with acepromazine and butorphanol. Unfortunately, with these herding breeds, a bunch of other medications have sort of been implicated in their prolonged recovery. But really, when it comes down to that P-glycoprotein or ABCB1 gene, really the ones that we're the most focused on are acepromazine and butorphanol. We don't really use a lot of barbiturates anymore in our anesthetic protocol. I am old enough to remember that we did use a significant amount of barbiturates, so we would always have to keep in mind our greyhounds and whippets as well. Boxers, apparently a lot of us are, nervous or hesitant, reluctant to use acepromazine in boxers, understandable. The latest discussion points regarding that are American boxers tend to not have the genetic lines to be affected inappropriately by acepromazine, but English boxers can. And I don't think a lot of people, when they're presented with a boxer, really deduce whether it's English or American. They just kind of stay away from acepromazine, which is understandable. And of course, brachycephalic airways and King Charles Cavalier Spaniel. So you have some patients who you get a call, hey doc, we've got this patient who's regurgitating. We have ingesta pouring out of his esophagus and out of his mouth. What do we essentially do about that? And we essentially know that esophageal reflux and regurgitation can be clinically silent. We know the esophagus has a pH less than 4, and sometimes propofol or 60% of opioids can cause this. Again, we're not talking about regurgitation here in this scenario where you can see it pouring out of the mouth. These are silent, right? This is where it's just bathing the lower esophageal sphincter or the lower third of the esophagus. And occasionally it can reach the pharynx and then begin to pour out of the mouth. So these are challenging because it can cause pneumonitis and stricture formation within the esophagus. And so the question becomes, what do we do in those scenarios, right? And if we had a regurgitation, we hear about it, we're alerted to it, do we suction out the pharynx and the esophagus and the mouth and rinse out the mouth? Do we just use tap water alone? Do we use tap water and suction, or do we use sodium bicarbonate, right? What options would we pick? And for all of you who selected the third option, I do think that that has some merit. I do think that that definitely has some merit. Looking at a particular study, and if it's difficult to see the title of that, I apologize. It says the effective topical treatment of esophageal pH during acid reflux in dogs, and they just dosed empirically, meaning they gave 20 mils for large dogs, and then they give 10 for medium size, and then 5 for small dogs. It was a sort of a very rough and dirty sort of calculation for these patients, knowing that this is being administered and going into an acidic environment, which is the stomach, and so it can be rapidly neutralized. However, just rinsing out the esophagus with bicarbonate can potentially be protective for the esophagus and prevent the corrosive nature of acid that will bathe the esophagus and contribute to stricture formation. So again, as far as postoperative care, what kind of remedies do we have for reflux? Number one, get a history. Okay, does your dog regurgitate at home? 2, preventative, right? 3 days prior to a brachycephalic airway syndrome dog starts on omeprazole and Cerenia, or your prokinetic of choice, and those are preventative strategies. And then when it happens, we have strategies for treating it in that event. Foreign bodies, we know that postoperative care in foreign bodies includes electrolyte management, pain medication, antibiotics, or if there's a break in sterility. And we have to be very particularly careful about dogs who are hyperproteinemic. And this can happen due to periphery, where we have third spacing in the periphery. We can see pulmonary edema or GI edema due to decreased motility. And what would be tragic would be dehiscence, right? So that is something that can be particularly bad. And of course, eating athletic attire with tags and things like that can be particularly dangerous as well. So for dogs who have a foreign body, definitely always consider either intraoperatively or preoperatively treating them with plasma. That's a preferred colloid. It just maintains their oncotic pressure. It preserves the blood volume. It reduces the risk of peripheral edema. And then, of course, for those patients who need a PICC line, it's great for monitoring, serial monitoring, and administering all the medications that are needed for supportive care without the need for constant venipuncture and potentially decreasing the fluid volume, particularly in our smaller patients. We don't want to exsanguinate them just trying to get our samples. So again, if you have a dog or if you have a patient who has a foreign body that has some history to it, vomiting, chronic foreign body, consider improving their postoperative success by utilizing an oncotic agent, a colloid like plasma in this scenario. And then, of course, in the postoperative period, if you do see these are challenging. If you see these big four, an acute onset of respiratory distress, hypoxemia, pulmonary infiltrates, and there's some sort of unknown trauma, whether it be vehicular trauma or something like that. If you see those big four, that's when you have to be very concerned about ARDS or SIRS, right? Or systemic inflammatory response syndrome. And those are the big four that we have to be concerned with. Of course, aspiration pneumonia is on a differential list, as well as fluid overload. But with fluid overload, you can certainly see nasal discharge, restlessness, a soft cough, and then some ocular changes as well due to fluid overload. So post-op fever, if we're seeing, okay, this patient just immediately out of the OR, why do they have a fever? We have to think about pneumonia, septic peritonitis. Pain can also cause a post-op fever. Dogs who have anxiety, high sympathetic tone, these are all potentials for post-operative fever. And we know that healing of the GI tract, the 3 to 5 days of where you were crossing our fingers, please survive, please heal the intestine, because we know that there's a lag phase between the time that you suture that intestine and between the time it is healed. So if there is a spike in the fever or an abdominal effusion within that 3 to 5 day lag period, that's when we do need to get a little bit more concerned about the potential for pneumonia or septic peritonitis. If we're out of those 5 days, then I would shift my mentality more to surgical site infection or an incisional infection or another cause for that. But septic peritonitis patients can be really easily identified by a fever and increasing peritoneal effusion. Of course, once you evaluate that effusion, you will see an increasing number of toxic neutrophils. And by that point, that's when you really should be suspicious that something is awry with your closure. Not necessarily human error. We know a lot of patients who are hyperproteinemic don't heal or have other causes. The viability of the intestine will cause dehiscence, but that's critical to remember. And then, of course, enteral nutrition. Post-operatively, if I have a concern about that, my preferred enteral nutrition sort of bypassing the oral cavity is an esophageal tube. I find esophageal feeding tube. I find that they're very easy to place or sort of straightforward to place. I find that they can be easily removed. I find that they tend to be very low profile. They don't tend to bother the patient. Of course, there's a variety of options, nasogastric or gastric or J through G tubes. There are a variety of options there. But if I had to pick 90% of my patients that need some sort of enteral feeding, I will usually utilize an esophageal feeding tube. And I always think that that's great to carry in your arsenal, not for the sickest patients, not for a last ditch effort, but just have it in your armamentarium for patients who have oral surgery or who have had a chronic history of foreign body, because even if they start eating, it may not be sufficient calories or meet their daily requirement, and they may need supplementation through the E-tube. Also, glutamine, the administration of glutamine. They found that glutamine can enhance the immune system and can be beneficial for enterocytes, right? And so the published dose is 0.5 grams per kg per day, divided into 2 or 3 doses. And it has been associated with helping the intestine heal. And it's something I would strongly consider in patients who have just had foreign body surgery. Postoperative blood work, I do like to use that for bullet number 1. I will use the term big 4 just so that everybody understands what I'm referring to. If I have a patient who just needs a postoperative evaluation of blood work and I'm concerned about the recovery or it's having a delayed recovery, I'll just ask, okay, I think we could just run a big 4, right? That includes PCV total solids, blood glucose, and a blood gas. A lot of times I say plus or minus specific gravity because a lot of these patients have already received fluids, right? And so for the critically ill patients, they'll need comprehensive blood work, but those are looking more for trends because we know, for example, for a comprehensive blood work, ALT has a half-life of 60 hours. And so that may not change. For our patients who are getting serial blood samples, I always just want to make a shout out for the smallest patients, right? Our toy breeds. We just don't want to remove 1% in a 24-hour period. And if we're going to follow that calculation in a 3-kilogram Yorkie, they have about a 240 mil total blood volume. That means 2.4 mils in a single day, 18 mils in a week, and nobody would use a 3-kilogram Yorkie as a blood donor, but I just wanted to complete the calculation there just for arithmetic purposes. So the total blood volume in most patients is going to be about 80 mils per kg. Right? And again, as we mentioned, for our septic patients, they're going to need significant more comprehensive blood work, and all of these will change over time. But what are we getting from the blood work? What can we assess from the blood work when it comes to postoperative care? If we're just looking at something, an example like a pyometra, they found that leukopenia, if they are leukopenic, they have 3.5 times higher risk of hospitalization, and a normal CBC is associated with an increased risk for prolonged hospitalization. So if you are seeing a patient, they come in with an acute pyometra, and you notice that the CBC has a normal white blood cell count, that's a conversation to have with the family that say, based on the blood work that I'm seeing, your patient, your dog, it has an increased risk of a prolonged hospitalization. That doesn't mean it will be the case for every patient, but it is important to remember. If they are depressed when they come in, 7 times higher risk of prolonged hospitalization. If they're pale mucous membranes, 3 times higher risk of prolonged hospitalization. Of course, the almighty lactate levels as well can be predictive as well. So I think if you are seeing a normal white blood cell count, they're depressed and they're pale and they have a high lactate, that's a patient we definitely need to be concerned about. Open fractures. You have a patient in vehicular trauma. We are getting closer to warmer weather out there. That means, unfortunately, a lot of dogs and cats will be off leash, which will unfortunately predispose them to vehicular trauma and other types of trauma. And I think open fractures is something that we may see quite a bit in these warmer months. And of course, that open fracture classification system is difficult to see. But I think the general point that I'm making here is that there are classifications here. So everything from a type 1, which very tiny wound, just a centimeter long, all the way down to type 3C with arterial damage, or type 3B where there's significant stripping and degloving injury of those tissues. So early decisions will impact final success, and a lot of them will heal without any sort of complications. But it's important to talk about the family when we talk about short-term, mid-term, long-term postoperative care. This is something that influences all of those stages. Open fractures do require more rechecks. They do require assessing the radiographic rechecks and assessing the bones. And it's important to discuss that with the family. So possible complications of open fractures that we discuss in the postoperative period include surgical site infections, non-unions, neurologic injuries, and of course, septicemia and death if it's untreated. So these are the kinds of conversations I think are really critical to have. Right? And again, I apologize if it's difficult to see, but I think it's essentially important to remember wound closure is critical for healing, and you can obviously delay closure until those tissues appear viable. I think that that's critical. And you could also use drains to help. I'm not a huge fan of drains generally. If I can avoid the use of drains, I will. However, there are some wounds that absolutely require it. And then vacuum assisted closure is really cool physiology behind that, using negative pressure to improve wound healing. But as you can see, a lot of those dogs require hospitalization while the vac is being applied, and sometimes it can get dislodged, and it doesn't always improve the blood flow like we'd like. So essentially, if you have granulation tissue and the wound looks healthy, that's a wound that can have a flap. If the tissue is not viable, then you definitely need to think about other wound treatment strategies. And I prefer a moisture retentive dressing. I prefer sharp surgical debridement, and then a tertiary closure, meaning a delayed primary closure once the wound is clean. I am less of a fan of vacuum assisted closure. However, I do think it has its purpose and its utility. I just prefer a different method. Again, looking at sort of post-operative care, this study looked at just evaluating protocol changes due to implant-associated infection rates. And so here are the things that they evaluated and changed just to make sure they can decrease post-operative surgical site infection rates. They used an ioban, right? They made sure that cefazolin was given every 90 minutes. They used orthopedic surgical gloves, which are obviously thicker. If you don't have orthopedic surgical gloves, you can certainly double glove. They used triclosan-coated intradermal sutures. This is controversial because when you're talking about the World Health Organization and the CDC, they do believe that using antibiotic-coated sutures do decrease surgical site infections. The jury is still out, meaning the evidence is not as conclusive on the veterinary side. They used a soft padded bandage using mupirocin. They used exam gloves when handling treated dogs. I can't tell you how many practices that I go to where I often don't see this. And it's, again, busy. People are busy. I get it 100%. And it can be easy not to remember exam gloves, but this is something they implicated in their protocol. So now with those, if we jump back to number 4, triclosan-coated intradermal sutures, now we see chlorhexidine-coated sutures, which in vitro studies was shown to have very important effects. I will say this. regardless of the species, if you were to do a literature search, whether it's equine, canine, feline, you will see a higher surgical site infection rate associated with skin closures, whether it be staples or skin sutures. They tend to have a higher surgical site infection rate, and that's just manipulation of the skin. So in the places where I will try to do intradermal or subcutaneous and then cover that with a wound dressing like a Hypofix. I remember when I was being trained, they said you should never do an intradermal closing over an orthopedic implant because it will result in dehiscence and disaster. And I just haven't seen that in the past 15 years. So again, you can do, as long as it's done well, you can do intradermal closures even in the face of an implant. There's different options here. There's a brand new topical therapy where we're talking about untapped remedies, right? We talked about conventional. Here's an untapped remedy, Keravet. This is the first keratin-based gel ointment. We know that keratin is really important in the course of wound healing, whether it be re-epithelialization or wound contracture or even granulation. We know keratinocytes do play a very important role in that wound healing. And so this is the first keratin-based gel that's available. It also has a lick deterrent in it as well. And so their sort of marketing discusses, potentially the absence of an e-collar. I would use this with an e-collar, but I would say let the family know that because it has a lick deterrent in it, perhaps we can decrease the time that the e-collar is on, but it would be difficult to know to use that only. We talked about antibiotic associated suture and of course respiratory, right? This is critical to know. I don't know if it'll play for us, but essentially what we are finding here.
The debate.
To wear the crown of most popular canine, it's really a dog-eat-dog competition. But apparently America has spoken, and the answer is the French Bulldog.
My buddy, she's my best friend. The sweetest dogs, crazy too. They're a lot of balls of energy.
The Frenchies really lapping up the limelight after the American Kennel Club announced their registrations leapfrogged the previous title holder for 3+ decades, Labrador Retrievers, who have a bone to pick with that dethroning. And so do their owners.
I'm a lab mom for life.
And why is that?
I think because of my lifestyle and their lifestyle.
Third on the list, Golden Retrievers.
And who doesn't love Golden Retrievers? But I think all of us are going to see more French Bulldogs in our practice. And I'm sure some of us have started to see a lot more French Bulldogs. And this situation is becoming even more acute because even with the spike in ownership of French Bulldogs, we essentially will start to see a lot of these patients get older, right? And as they get older, they're going to require more care. And so I think that that's really critical to remember. Most common cause of depression of the respiratory center from anesthetics or analgesics. I think that's really important to remember. We can see respiratory obstruction in these particular patients and ultimately pulmonary infiltrates, like as you can see in this radiograph here. So whether it's airway obstruction, there's issues of the cervical spinal cord and neuromuscular disease, airway, having respiratory acidosis is something we have to think about in our postoperative care regimen. This is the BRISC score, right? On how to predict complications in dogs presenting for treatment of BOAS surgery. And my take on this, or essentially my message on this is a wonderful tool to use for every patient who comes in who has brachycephalic airways obstruction syndrome, regardless of whether they're presenting for BOAS surgery or not. If they are presenting for a different procedure, it's still important to remember that these are important risk factors for having a issue or having potential postoperative complications. And as you can see, if they present with a low body temperature, then that can be a risk factor. And of course, English Bulldogs certainly are predisposed to having postoperative complications. I would say the signalment that I'm the most concerned with would be an older, obese English Bulldog with a low body temperature and who's been chronically affected with brachycephalic airway syndrome. That, for me, would be a signalment that should make everybody stand at attention. Sweet guy, but certainly we have to really be careful about respiratory acidosis in these patients. We're seeing, if you see clinically an increase in respiratory rate and effort, oxygenation, we're looking at a drop in that pulse ox or a drop in the arterial blood gases. And then as far as how they ventilate, we're looking at that end tidal CO2 and making sure that that is not increasing, right? And so the bottom line is trying to use all three. Use your clinical assessment, how are they oxygenating and how are they ventilating, particularly for these patients, right? We'll just pass over pulse ox, but I do think it's important that one sort of remedy for postoperative care would be nasotracheal oxygen. So after you have finished your brachiocephalic airway surgery or tonsillar surgery or oral mass surgery, or even a dental cleaning, is while they are anesthetized, is using the medial corner of the nares and passing a 3.5 or a 5 French red rubber, and then visualizing that coming out into the pharynx from that soft palate, and then guiding that into the trachea. And now, once they're extubated, they have indwelling oxygen, and they just recover very smoothly, and it's a very low profile, and they barely feel that there. But it allows your patients, if you have multiple patients and don't have multiple oxygen cages, if you're concerned about the sort of the inefficiency of an oxygen cage, or patients don't do well in an oxygen cage, you have nasotracheal oxygen as a potential untapped remedy for that, right? And I like to, if we're recovering from anesthesia, I like to keep them in sternal recumbency. I like to keep the area quiet. I know this seems like such a simplistic discussion point, but I can't tell you how many patients that I've seen in hospital settings in recovering, and there's a lot of noise and dogs who are vocalizing around them. This can be particularly acute scenario for cats, and we obviously extubating to the last moment possible, and as we just discussed, can benefit from oxygenation. So, and just be prepared. So even if I'm doing a laryngeal exam on, let's say, an older golden retriever or an older Labrador retriever, that's not necessarily a benign or anodyne procedure, right? Just a laryngeal exam. That can throw that patient into crisis. And so I think when you're talking about postoperative recovery, a lot of times we're thinking about surgery, but even for patients who aren't having surgery, I think that that's really important. When looking at sort of postoperative recovery in these patients who have had oral surgery, you're looking at a human study here where they used ice lollies for pain relief in post-pediatric tonsillectomy. And they did a single-blinded randomized controlled trial. And what they found, the ice lollies were cheap and effective, a safe way of reducing postoperative pain, particularly in that 1 hour afterwards. And so, sometimes if you can, sometimes you could just create your ice that's cylindrical. It can go in a glove, obviously, and then that glove can go in the back. Now, to be honest with you, that ice melts in pretty quickly, but of course it should, because it's in a very warm oral pharynx, and that can just provide some pain control postoperatively as well. And then at temperatures, this is fairly rudimentary for all of us, but I just think I just have to double down on this can cause a delayed recovery. We just talked about that, right? In terms of you have vasoconstriction agents, depending upon which preoperative protocol you're using, the clipping, the open body cavities, the reduced muscle activity, all of that can cause decreased postoperative temperatures. I prefer to use something like a warm water bath, hot dog, or warming agents, or even forced warm air. You have to be careful of using forced warm air in the OR. Obviously, there have been discussions about increasing the potential for bacterial colonization with forced warm air. So again, I try to utilize that in the postoperative period. For Cheeto here, he had the issue here as his family's trying to decide which direction they're going to go. He's definitely needs to be warmed right there. He has a blanket that's been reflected just obviously to capture the injury that he had, but immediately after this, he started to get warmed up prior to entering surgery. And utilize all the tools at your disposal, whether you have an incubator, a cocoon, a hot dog, or even an electric fluid warmer, which is fairly controversial of whether or not it's effective, or having a cocoon underneath the blanket. But you have passive, active, and core warming. And I would just say utilize one in each of these categories. And that's kind of what we did for Cheeto, as we'll see in a moment. And so just the prevalence of hypothermia in dogs, they looked at baseline temperature and body surface area, physical condition, and then the duration of the procedure. Those are the three main things that they looked at. And physical condition, dogs who are a higher ASA score, as we showed at the beginning, showed the lower temperatures. Dogs who had the greatest drops for thoracic surgery, they had the greatest drops. And dogs who are in sternal or dorsal recumbency rather than lateral. So again, we're thinking about post-operative recovery, if we're thinking, okay, this dog's going to need thoracic surgery, it's a critical condition, and we're going to basically be placing him in sternal or dorsal recumbency, that's when we know, okay, that's when we really have to be careful about our post-operative temperatures. For Cheeto, same sort of issue. For heat support, did we use warm lavage, forced air? Did we use towel padding? Did we use a radiant heater? We actually used all of the above. So for Cheeto, we were able to use warm saline lavage. We instilled that in the abdomen and just let that sit. And we suctioned that out twice. And then we put forced warm air and then kept him lightly anesthetized until his body temperature got to be about 95, just to prevent that severe shivering and the stress associated with that severe shivering. And then for him, we just used a radiant heater until he got to about 98, and then we removed that so that his temperature, didn't become hyperthermic. I would just use towels, and we took those right out of the dryer. So I think utilizing all of those are important. A friend of mine just showed me this picture. Unfortunately, he, I believe, didn't have his normal forced air is bear hugger working, and he decided to use a radiated heater, which is something he doesn't typically do. And as you can see here, it ultimately caused burns. So it's important to know that if you are utilizing a new piece of equipment, is be careful that it can cause burns. As I mentioned, IV fluid warmers are a little bit controversial. Looking at this one study on the left, looking at it said no effect in small dogs. I'm looking at this study on the right, pre-warming fluid before general anesthesia delayed the onset of hypothermia in rats. So certainly take that for what it's worth for all of those of you who are operating on rats. I guess I would certainly say it has some protective effect. For those of you operating on small dogs, the jury is still out there, right? We'll just move forward on this just because we do have, I do want to talk about some sort of untapped remedies for all of those of you who were hoping that we got to arrhythmias. We could certainly do a round 2 and talk about it, but the key here for arrhythmias is, should we treat them, and just having conversations with specialists. If you can get one on the phone, perfect. I would say that would be the number one. Speak with a cardiologist, speak with a criticalist. However, if you can't, then I think that it's important to think about what's the heart rate, and are there active pulse deficits present. If we have heart rates that are above 180, if that patient is not volume resuscitated and there's active pulse deficits, that is a patient that may need their arrhythmia treated. There are some people who feel like the best way to treat an arrhythmia is to simply turn off the EKG. I would definitely not recommend that, but I would certainly say for risk factors, we're looking at risk factors, even in this particular study, looking at gastrointestinal GDVs and looking at short-term outcomes, development of perioperative complications. They found that 50% who had cardiac arrhythmias and they needed therapy after that. So those who had an increased risk, if you're doing a partial gastrectomy, you can see arrhythmias. If you're doing a splenectomy, you can see arrhythmias, and 75% postoperative arrhythmias within the first 24 hours. And lidocaine is going to be our friend in these situations. And I think all of us know the doses of lidocaine. We have to be particularly careful on cats. They are sensitive to it. And then oral. By this time, I hope that you have spoken with a cardiologist or criticalist to figure out, do they need sotalol versus mexiletine? And I would say that sotalol has minimal side effects and it's less expensive. But if the patient has congestive heart failure or other systolic dysfunction, then mixilotine is the one treatment of choice. Fluids, in terms of postoperative fluids, I just think it's important to remember that we just don't want to fluid overload these patients. It's critical in the postoperative period that we have to think about the trauma, the stress of surgery, significant blood loss, third spacing. Cheeto had significant third spacing to the intestine, so he did receive some plasma prior to anesthesia, as well as intraoperative infusion of plasma as well, because I knew that he potentially may have that. Cheeto, what's interesting about Cheeto is he did have he did have a very thorough pain management protocol, but he actually benefited from the addition. He actually benefited from the addition of dexmedetomidine, and I think that that's really important to talk about because, with dexmedetomidine, for Cheeto, he had his FLK-CRI, he had lidocaine given separately in the FLK, he had a tap block, he also had Nocita infused into the tissue planes both upon closure. He received an NSAID, and he was also on FLK in the postoperative period. But he still seemed to be a little bit restless until we added a very low dose of dexmedetomidine CRI. That's when he really seemed to benefit. And I just want to re-emphasize that there is an allosteric change to the receptor. When you give an opioid, it makes that receptor more receptive to an adrenergic pain medication like dexmedetomidine. And conversely, when you give dexmedetomidine, it actually makes it more receptive to an opioid. So you essentially get this synergistic or additive effect when you combine an opioid with dexmedetomidine. Even at low dosage, like a 2 microgram per kilogram dose, you will see a very beneficial effect, even in patients who receive buprenorphine, which is sort of maligned for being a partial mu agonist. But even if you were to give buprenorphine combined with dexmedetomidine, it can be beneficial. When we're looking at safety and efficacy of dexmedetomidine, I know that some people can be nervous, particularly in our critical patients. This is a human study looking at cardiac surgery patients, and they found that cardiac surgery patients can reduce the risk of abnormal hemodynamics with good safety. Looking at another human study, looking at those with septic shock, they received dexmedetomidine, and they had lower vasopressor requirements to maintain the target, maintain their target blood pressure. And then also looking at another study, they mixed opioids and dexmedetomidine, and they found that it decreased postoperative pain, postoperative requirement of opioids, and opioid-related adverse events. So again, on the human side, they are using it fairly frequently everywhere from cardiac patients to septic patients, and I think with caution, we can do the same. We'll skip over wound healing now, but I do think that there's some options. We did use fluorescence biomodulation therapy in Cheeto. Ideally, you should have had sort of a closed suction drain there in those scenarios. That's my preference. That particular hospital did not carry those, but I do think that he healed very well with Penrose's, and we were able to use fluorescence biomodulation therapy. And the reason why you use fluorescence is because it hits all of those light wavelengths to help. Now, last what we'll talk about is patient comfort. Just quick hits here. Wetting nose and tongue right after extubation. When you talk to the human side immediately after anesthesia, they find that there is benefit to that, where they have that dry mouth. Consider evacuating the colon. And there are then limbs or parts of the body that are non-dependent. We could lay them down on the opposite side. And then tight catheter taping. We have to be careful of that in the postoperative recovery. And then use a gurney. I see so many people carrying dogs out of surgery, and then allow the patient to rest in a very comfortable, a very quiet environment. I find that that's important. And then for those dogs, immediately after surgery to recover in the cage, just emptying their bladder can be really helpful. And then key here is hands-off monitoring. Let's talk about continuous monitoring, because that is an untapped remedy. When you're looking at, on the human side, they're looking at anesthesia patient safety. They said the consensus of conference attendees was that continual electronic monitoring should be utilized for inpatients receiving postoperative opioids. So on the human side, they're saying we need continuous monitoring. Spot checks are not enough. And what are the benefits of remote continuous monitoring? Vital signs, detecting early complications, pain management optimization, right? For Cheeto, he was restless. We added dexmedetomidine. It definitely benefited him. If he had continuous monitoring, we could have detected that a little bit earlier. More benefits, everything from respiratory functions, and then even for patients who are just recovering from a sedated procedure, right? Sedated radiographs or sedated skin scrape or sedated true cut biopsy. All of these can benefit from remote monitoring. And then when you have these programs, they can always log that into the computer for you, and you can use that for telemedicine consultation with other professionals and discuss the case with them, right? And share that data with them. And you can assess the surgical site effectively and then look for postoperative behavioral monitoring. So how can we do continuous remote monitoring? How is that possible so that we don't have to continually do spot checks? And that is with the Vet Guardian right now, it's the only instrument, it's the only device that I'm aware of that can do remote monitoring using zero touch and utilizing radar to give us the vital signs that we need. It uses the algorithm, creates a heat map. Once you enter in those vital signs, it will give you those numbers based on the algorithm, and you can just have that up continuously. And it avoids the use of all of the most valuable people in the hospital, or all the talent we have from our registered veterinary technicians and our veterinary assistants and all of the staff. They are so talented, and we definitely want to utilize them effectively. And so utilizing Vet Guardian gives an option, right? And it gives a more cost-efficient option, reduces patient stress and safety, and then of course staff safety too. How often are we going into a cage and worried that we're going to get bitten? So we can upload all of this information and share it with a specialist. So it's contactless, gives you push notifications, alerts, and it gives you a live video and thermal imaging, which is key, and the cloud-based. So that is kind of the focus here. I decided to use it on my ugly mug just to see if it would work there, and apparently it does, right? I entered in all of my information into the computer, and once it did, it actually gave me a nice heat map, just taking a look at, using that remote monitoring system. And once it did that and I gave it the alerts that it needed to sort of sound off, it started to do that as well. So that is I will say, certainly if it worked on me, then I know that for our patients. Now, the key with the Vet Guardian, the patient does need to be still. It's not going to work on a patient who's circling and pacing and things like that, right? And then the question is, does it work, right? Does it actually work? And so looking at particular studies, they said, all right, we'll use manual, a device that has leads, and then a device that has zero touch. And they admitted 10 dogs to the hospital and said if it works. And as you can see, based on these maps, looking at manual, one with leads, and then looking at temperature and pulse and respiration with contactless, you can see that those charts are all pretty similar. And so their conclusion was the Vet Guardian provides similar accuracy for vital sign reads as veterinary multi-parameter monitoring that have leads as well, right? So it can be helpful in a clinical environment. And of course, it does save some money, which is absolutely critical. It just takes a minute for a calibration, looks for that biosignature, and then it looks for micromotion before it creates that heat map as well. All right. So thank you all. I appreciate you, joining the webinar today. Sorry we went a little bit long, but as we mentioned, a lot to discuss in postoperative care. And I'm just so thankful for all of you to join me tonight.